Thank you.
Thanks so much, and I'd like to thank the Cancer Center for the opportunity to share with you a range of the kind of topics that we're exploring in the Pet Center when we talk about novel pet imaging. So what I'd like to do today is first take you on a brief tour over in the Pet Center. It's not a far walk from here, but you don't get in there too often just to see some of the cool toys that we have. Talk about some of the novel imaging approaches we're using with the classic tool used in cancer, that is fluorodeoxyglucose, or FDG. And then go on to looking at other targets using other radiopharmaceuticals, whether we're looking at hypoxia, labeling of drugs, looking at drug delivery, or some of the newest directions in antibody imaging or imaging of PD-L1. So to start, if you walked a block and a half away and dug down into the basement, Pet Center is always in the basement, you'd find our cyclotron that we make our isotopes. And primarily the two isotopes we work with are short-lived, carbon-11 with a 20-minute half-life and fluorine-18 with a 2-hour half-life. And we routinely make 4 to 6 different molecules today that get administered to human beings or to animals or both. We have a place for turning those radioactive molecules into drugs, into radiopharmaceuticals, with a team of chemists, and doing that and following all the quality control procedures that the FDA requires. We have 3 human-scale scanners. For the purpose of cancer studies, most of our work is done on a clinical scanner called an MCT, a PET and a CT put together. We also have dedicated scanners for brain imaging. Along with our human scale, we have animal scale scanners. We have smaller ones for doing medium-sized animals, or a micro-PET CT for doing rodents, along with the CT that goes along with those. This tedious slide is actually something I'm very proud of, that we work with a lot of different radiopharmaceuticals. We've injected over 51 different radioactive molecules into human beings to date. We're doing 3 to 5 new ones per year. And we're exceptionally excited about, as we build the collaborations in cancer, that area, the applications will grow tremendously. This is relatively unusual for a Pet Center, and I think it's something that really lets pet have its promise, and particularly in oncology. We also try to not just produce pretty pictures, but generate good numbers. And by doing quantitative measurements with dynamic scans, here I'm showing that in a brain application, where we're able to take the radioactivity images and turn them into physiology, and measuring that on a fine regional basis with high resolution. But let me take you back into the clinical world. If you're doing here, you send your patients up for an FDG scan, you might get a quantitative readout called SUV, standard uptake value. It's the typical thing. It's straightforward to get out clinically there. What do? You take the activity that the scanner measures, and you just normalize it for the injected dose and the body volume. It's easy. It's somewhat useful. It has some quantitative measures there. It's got some advantages and shortcomings there, but it's clinically very simple to do, to be quantitative. But there's a lot more that we can do. So here's an example of what those SUV images look like in a whole body scan. In a cancer, we're looking at a lymphoma, an SUV of 8.9, but comparing it to other activity in other organs, whose uptake for FDG may be by a different mechanism than why it's being taken up in the tumors to measure its proliferative capacity. One thing we can do in a research environment is scan people and animals for a longer period of time. We can collect data over time, recognizing that if we scan at a single time, our ability to differentiate one tumor from normal tissues or from another is different. So if I scan at this period of time, this lymphoma, I can't differentiate that from normal liver. At other times, I have more information. So if I can use all of this information in an appropriate way, I can get out more physiologically relevant images out of that. Well, what do we have to do that? We have to measure the availability of the tracer, because it's different. If I took syringes of FDG, injected in all of you, you'd all clear it very differently, especially because you're eating lunch. So here we would be able to measure what that activity would be in the blood pools of the person and be able to measure that from the scanners. In the research environment, we validate that with blood samples. And we can measure this time course. We can produce these images called Patlack images, named after a great mathematician, where you can fit a slope to the line. And basically what we're doing there, instead of just measuring the uptake at one point by using the dynamic scan, we do 2 things. We account for differences in the availability, how the tracer clears from one patient to another, and we can also get rid of the unmetabolized FDG, the part that isn't telling us something about tumor metabolism. Now, that may not be too important for a very rapidly growing tumor, but when we're trying to differentiate slowly growing tumors from normal tissue or something that's benign or more serious there, this kind of quantitation in principle can do better. So here's an example where we've taken that same patient I showed you before, and now we're showing you something different. This image where the number isn't the radioactivity, it's the net uptake rate. And what we've done is we still see the lymphoma beautifully, but we've suppressed the liver because that uptake is not specific to showing metabolism of FDG. Now, you also probably notice the image is a little bit noisier. You don't get something for nothing. And the idea is, can we get a better signal at the price of getting something with a little bit higher noise? So one question we had, and this was a study led by Chi Liu in collaboration with the thoracic surgeon, with Lynn and Frank and Justin in thoracic surgery, to say, would dynamic imaging help you discriminate when you're following somebody, you see a lesion in lung cancer, and you're trying to say, is it benign or is it malignant? And to do so, the challenge of that is if you wanted to add PET to that following, you'd be adding more radiation dose in a case where there's very few significant positives. And we'd like to do this at low dose. So we'd like to do two things: add dynamic scans, which gives us more activity, more measurements, but at the same time, reduce the dose. So here's an example of what the images look like here in the research protocol that we have, and in this case, an 8mm nodule. This is the scan that we acquired, whether we're doing SUV or the KI, the metabolic measurement, or just the uptake measurement. We can simulate what would happen if we injected less. And in terms of your ability to distinguish and identify the tumors, honestly, the SUV image shows you a little bit better. And that's why it's used diagnostically. But if you want to quantitate something where you know where it is, because we know where this tumor we're following it is, the ability to get the quantitation can be more important. So we did various numbers of simulations to say how much counts could we do. The prediction is at 10% of the count level, a big reduction in radiation dose, we'd be able to get a measure that would be as good as the 100%, especially because we know where we're looking. We know the site of that tumor. And then, because we only have a small number of patients to date, we did a simulated or a virtual clinical trial using all of the data that we have, simulating the variability of patients across the types of tumor uptakes, as well as all of the different sources of variability in the data, everything from how people clear the tracer or the timing of a scan if you're only doing an SUV scan, which can vary based on clinical need. And what we find when we do the ROC curves is that if we do this PAT-LAC analysis, we can get improved, in this case, an improvement in the specificity. So if we look at the just CT alone, we have good sensitivity, but not so great specificity, 73%. If we just add SUV, not a big improvement, but if we can add the physiological information, we can improve the specificity. And part of our challenges now is how to do that at lower dose, because if we lower the dose too much, we don't get that specificity back. So by using some more state-of-the-art imaging techniques and figuring out how to translate them into the clinic, we have the opportunity to get a little bit more, particularly specificity, which is very important in the lung cancer application. One of the nice things that's happened very recently is the same PET scanner that we have in the PET research lab, the identical machine has just been bought into the clinic. And that's going to make both our ability to have access to more data, to be able to translate, as well as to more rapidly translate our research results into clinical reality. Now, one of the other aspects of clinical reality is that patients breathe. It's very disappointing, but we've tried to ask them to hold their breath, but 20-minute scans are a little challenging. And so we need to handle that. And for a long time, the PET physics community has been tackling that, and a lot of that's been led by one of our associate professors, Chi Liu, in the group. One approach is to do a gated study where we only collect data at a certain time during the respiratory cycle. And here's an example of a small tumor in the liver, which you can see beautifully when you correct for respiration, but if you blur it out based on averaging over different breaths, you lose that signal. Challenge, of course, is that when you only use a small portion of the data, the image has that mottled, more noisy look. So we've been developing a lot of technologies and trying to be able to improve that. Right now in the research environment, we measure that. We attach a device to the person to monitor their breathing. We get this breathing cycle. We can segment that into different periods and determine the relationship between this external signal and the internal motion of a tumor. And by doing that, now we've gotten to the point of handling that, recognizing that people, when they breathe, it's not a rigid motion, it's very non-rigid. So we've got a very complicated algorithm that I won't walk through, but be able to take that data and turn that and correct for the whole dynamics of motion as you breathe. And do that on not only a second by second, but a millisecond by millisecond basis as we collect our data. So here's some examples of what that would look like. The uncorrected data, where we just have a blur, what's called non-rigid, internal, external. And for comparison, we show you, if we just showed you one gate, that is where we frozen the breathing, but at the expense of giving up most of the counts. So if you look at the various lesions, you see how they're generally blurred out. In the uncorrected state, you can see them fine in the gated study, except that it's noisy. And when you add all the data, you get the best of both worlds. And as you walk through, you're going to see that focus, that sharpening of the lesions that we get. In fact, when we scale in, we can even see in this tumor, which has a necrotic center, a much better visualization and separation of that. That's really relevant because when we blur that out, we don't have an accurate measurement even of that SUV, of that high intensity that's there, to be able to know, is the treatment working, or what should be the treatment path for this patient. But practically, people don't attach things to patients for clinical scans. It just doesn't happen. And so what we really need is to be able to do this without in some very simple way. And so the other direction of the research is say, can the scanner tell us how they breathe? Here's an example. It's there done in a study of the pancreas and the kidneys where we can detect the measurement just by how the counts are moving around on a second-by-second basis. So we can measure this, what's called centroid of distribution, which shows a breathing pattern compared to this ANZI, the external measurement. And so this works well in certain cases, and we're currently doing that research to say, how can we apply it? Because this is the tools that we're going to need to get this into the clinic for routine use. Now, I've showed you human images with FDG. All over the world, people are using FDG in animal models to be able to look at all of the precursors before they take something into humans. Here's an example on our collaboration on the lung spore project with Peter Ku's KRAS P53 double mutant rats, showing how we can easily image a very realistic tumor here in the lung that, even though not a focal point, but something that's a little meant to be more clinically relevant, be able to do that. And I could go on and on showing you FDG scans, but we think we have things I think we're better. So overall, I mean, if you look across the world, both human and preclinical, FDG is the workhorse. Now, I'm a math guy, and I have tried to limit the number of equations here, but I'm going to show you one equation, and I'm hoping this is the take-home message, the one equation from your talk that I hope that you will remember after this talk, that PET is more than FDG. And if you can learn that, because honestly, this is where we can do some fabulous novel imaging by having the right molecule specific. FDG is hugely useful in many applications, but by targeting the specific molecular processes going on, we could really extend its utility. So let me walk you through some of the examples of what's going on currently in the PET Center. Here's an example of a collaboration looking at melanoma, looking at brain metastases there, where here we've been able to introduce, this is Marcus Bosenberg's one mouse model there, be able to follow that even in a mouse in that small resolution where we can see the tumor, or here how we can differentiate in two different cases a treated tumor from an untreated tumor. And these are exactly those kind of preliminary studies that we would do to be able to say, will this work well in the clinic for differentiating, in this case, the effectiveness of treatment. In the brain, for example, with high uptake of FDG, it's not very useful for doing that. Here, using methionine, an amino acid with low normal brain uptake, we can use that because of the higher uptake into the tumors. Now, one area that's of huge relevance is that of hypoxia and how that ties into the efficacy of all kinds of radiation treatment. And for a long time, PET's been very active in a number of localized research centers trying to develop tracers that are sensitive to hypoxia. And the one that's been most used is fluoromycinidazole. And the trick here is that by injecting this molecule, it's sensitive to the oxidative state of the local tissue. And that depending on what that oxygen is, it's either going to be charged or an uncharged state, and that will affect its clearance. And this is designed beautifully because if the molecule, if there's low oxygen there, the tracer goes in its charged state, it doesn't clear from the tissue, we get higher signal. So here's some example of what one of those scans looks like. We have the CT on the top, and we have, in this case, non-small cell lung cancer there, and the high uptake here in a hypoxic tumor taken here about 3 or 4 hours after injection of fluoromycinidazole. One of our early studies in collaboration with David Carson, Ming-Kai Chen, and Roy Decker, where we're looking at multiple radiation therapy before and after to see to what extent we can induce hypoxia or alter hypoxia state, which would affect the decisions on radiation treatment. And so, although this is a little bit too complicated in this slide, if we can follow on those changes following the same person over a few days before and after radiation treatment. And in a recent protocol, and this is one that we're doing in collaboration to look at combination treatment. In this case, this study, and this is an NCI study where we're doing a combination of cediranib and olaparib. The overall idea of the study is that the goal of cediranib is to induce hypoxia, and that's going to increase the effectiveness of the PARP inhibitor olaparib. But the question would be, is the dose right? Did cediranib work? This is a place that PET can play a huge role. When you have a mechanism in mind, that's going to be the mechanism of action. And if we can image that mechanism, then we could say, well, did the trial work? Did the dosing regimen work? It may be that the mechanism just doesn't make sense in that particular tumor, and we can validate, did the mechanism have its effect? Did you have that? Or it may be that we didn't have enough dose, or we didn't have enough efficacy in what we're doing. And here, that goal is to be able to say, are we inducing enough hypoxia in there? This trial is just getting off the ground. Here's some example data. Somebody taken at baseline and then 5 days post-treatment with cediranib. And again, we're looking here in the cancer and being able to do it not just by visualization, but by measurement. We can do that. Here's the baseline values here shown at different times post-injection. F-MISO is one of those that waiting a little longer gives you better contrast. So here we've got about a 15% increase in there, suggestive of a mild induction of hypoxia in this by there. So I have to collect a lot more data sets And this is a collaboration with Joseph Kim and Ming-Kai Chen and Pat LaRusso. So it's exciting to see how this plays out going further. Well, along with this, we can label drugs. Now, you can't, it's not like, please don't ask my chemist, hey, here's my drug, please label it for an hour, because it is a little more complicated than that. But here's an example of one that you're familiar with, erlotinib, that happens to be readily labeled with carbon-11. Remember, that's the short half-life, the 20-minute half-life. When we scan things with 20 minutes, everything's got to be, patient better be there on time. Here's an example of the preclinical work that was published a few years back. We relate with Joe Contessa and Evan Morris, where here we have 3 different tumors that are implanted, different xenografts in this mouse, and where 2 of them have EGFR with the kinase domain mutations, and 1 has the high affinity state. So here's a case where we could say yes or no, is there EGFR, and even yes or no, is it in its mutant state or its wild type state? Because in the mutant state, we have higher affinity. That's going to give us higher contrast. We can see that in the rodent with its time activity curves there. And in an NCI-funded study that Evan Morris and Joe Contessa have ongoing, we've begun to take that into humans. Here's an example of somebody who is the wild type. There's only a small lesion. The activity curve is quite low. And in fact, based on autopsy, we've been able to demonstrate that this is a wild type lesion, that it does not show the high affinity, which would also give higher contrast in the later study. So why do we want to do this? I mean, can't we just biopsy them? Well, that's true, but this in one slew will give us all the tumors simultaneously. We're going to be able to assess their heterogeneity, and we're also going to avoid any of the missteps that may happen depending on the nuances of how one samples a tumor. We've also been involved for a while of trying to image drug delivery. These are in collaborations with Mark Saltzman, Zhongbing Zhu, and others in biomedical engineering and elsewhere, developing different nanoparticles or other formulations to be able to say, did we get the drug to the tumor? Again, that's that mechanistic step. If a nanoparticle doesn't work to reduce the tumors or improve the response, maybe you just didn't get enough there. Here's some early work that we've done using a biotin-actin mechanism where we can label the nanoparticle. We're able to do that. We've gone on further with Zhongbing, where he's got something that's going to break down the blood-brain barrier, so showing some images in mice, where we can break down the blood-brain barrier and deliver the agent, and we see it when we give the autocatalytic target that he's developed there, that it gets into the brain compared to the control animal with an intact blood-brain barrier where it does not get into the brain. And so what's nice about that is you can develop these proof of principles in the animal and then do the same imaging in the human being, in this case tracking the delivery of the particle. I was really hopeful that I would be able to share with you some results on the lung spore, that we had started a collaboration with Roy Herbst's spore to work with Myrna and look at their microRNA deliveries. And unfortunately, thanks to changes in that trial, that didn't happen. But we're currently reformulating that aim, thanks to Ed and Roy, and just being able to say how that will work. Again, working with Mark on some new nanoparticles and for delivery of agents, microRNAs in particular. Now we have one real big new area for us, and something we've been working for a long time, is to be able to go beyond some of the short-lived isotopes, carbon and fluorine, and go into being able to look at longer-lived isotopes, allow us to image large molecules, antibodies, peptides, et cetera. And we've really been fortunate to have recruited Bernadette Marquez Nostra, who's over here. I think she'll be giving grand rounds in a couple months here, so you'll get to hear these slides in more details. If you have questions on them, ask her. What that allows you to do is label antibodies, label monoclonal antibodies, label peptides in ways where you can image them, but also by adding the right isotope, you can also do theranostics. You can do therapy at the same time. And this is a great and spectacular approach. To do this well, you're going to need some of these longer-lived isotopes that have the appropriate isotopic release to be able to treat the tumors. So the main idea certainly is that we're going to have our probe, we're going to have some kind of radioactive molecule, and some kind of specific mechanism for having it accumulate at the tumor. And this is where we need more time. Time is what we do in terms of isotopes. So the isotopes that are used are things like copper-64, which is about a 12 or 13-hour half-life, and particularly zirconium-89. It's got a 3-day half-life that allows the time for it to accumulate in the tumor, but also, more importantly, to clear from the background so you can get accurate imaging and avoid uptake in organs that would conflict with that. And the nice part about that is the syntheses of these, by having appropriate chelator built in and attached to the antibody or attached to the peptide, the introduction of the zirconium is relatively straightforward. And they're currently building a lab on the 6th floor of LCI for Bernadette, which will have a clean room, being able to produce this not just for animal work, but also directly for human work for imaging at the Pet Center. So here's some example of previous work that she had done, working with labeled trastuzumab, being able to do that with zirconium-89, to be able to look at that here in metastatic breast cancer, be able to do that again with whole body imaging there. And in some other work, it's funded by her R00, trying to look at the glycoprotein non-metastatic melanoma B and triple-negative breast cancer. Here's an example in animals with xenografts where you see the high uptake of the zirconium-labeled drug in this case compared to the wild-type animal, which doesn't show those uptakes. Again, pairing what we will be doing in humans to what we'll be do first in mouse models. This is going to let us know what's the time course of the uptake here in days, what's the optimal time for imaging so we can do something in a convenient, clinically relevant fashion, as well as get good quantitative results out of that. Last topic, something I don't have to talk to this audience about probably, PD-L1, and the relevant importance of immunotherapy and how that's revolutionized what we're doing in cancer. And to add a little bit to that revolution, we need to be able to image it as well. We need to be able to see where is PD-L1, how does that change with disease, how does that change with our treatment. So, for example, we've started by participating in the Checkmate 592 trial from BMS. Scott Gettinger's the local PI on this one. Combination of the PD-1 inhibitor nivolumab with ipilimumab. Never get the pronunciations right. This is a multi-center trial. Some will be following it with biopsy, some with FDG, some with just CT. But there'll be one very unique thing that will happen only at Yale, is to image PD-L1 itself at the tumor. And of course, the patients here have been biopsied, so we know if they're PD-L1 positive, but we'll be able to look at all of their tumor sites. So here's the mechanisms there, and this is work we collaborated with BMS. They did some of the initial developments there, where they have a particular targeting vector that's going to be specific to PD-L1, a generic linker. And so the synthesis of this molecule is done in our PET center, and since it's labeled with F18 with a 2-hour half-life, obviously we're making it right on the day that we're going to be injecting it in our human beings. Here's some of the preclinical work to be able to show that there is selective binding in the PD-L1 positive xenografts, not present in the negative ones, and that you can also block it. Here we had a cold drug that we can give to completely block PD-L1 and demonstrate the high specificity of the target. So here's some of the images we've collected here. One of the first markers using a large molecule where we can see both a primary tumor and a metastasis there. And like most things, we're going to not only just take a single image, but start collecting data over time. Because one of the challenges we'd like to know is, what is the best way to interpret this data? How do we correlate the imaging biomarkers to what we can learn from biopsy, and how to do that in a clinically relevant way? We're going to measure the uptake in the tumors, which is slow and gradual, as well as the clearance in the blood, because that's going to drive what we see in our signals as well. Here's a second tracer. This is the brand new, so you're seeing images. No, I don't know if anybody's seen many. No, this has never been presented to a group before, so you're seeing some of the first images of this tracer with the clever name 986229. Another agent, a little smaller molecule, a little bit more reliable to synthesize. And when we compare these two molecules, and we've got to do this on a much larger group, our big measure is looking at the tissue, that is the tumor to blood ratio. And although we're not achieving huge measures, we have enough to be able to image this well. And the smaller molecule, the 229, seems to achieve its contrast at a little higher point. But we have much, much more to do in this area. So this is a spectacularly exciting area of the many that we're working on here. We're doing this first head-to-head comparison of these two tracers that we're making here. We want to know how to do this when we're trying to image and extract values for PD-L1. Is the dynamic information well? Can we identify how to normalize to other areas? What would be the best way, and just to look at how heterogeneous the uptake will be within tumors and between tumors in the same patients. Then, of course, the relevant clinical questions. Does the uptake of this before treatment tell you something about the clinical response? Is the amount of PD-L1 that's present there going to affect when you're doing a PD-1 inhibition? Could we actually use a tracer for patient selection? Or a really relevant topic right now with all the adverse events coming from immunotherapy is, can we learn something to predict those patients who are going to be sensitive to the adverse events? And we have a grant that's under review right now to look at this. And what's going to be extended in the very near future, there's a GBM trial that Joachim Behring is PIing there, and we're going to be trying this to say, can we get it through the blood-brain barrier that's intact? Probably not. What we'll be able to see in the tumors that are there. So I hope I've given you a good feel for the kind of range that's going on now in the PET Center. It takes a large group. It takes a village to do PET of all the different kind of specialities that we do. It takes some funding. The NIH has been particularly relevant. Siemens has been helping us with some of those FDG work, BMS and some other pharmaceutical sponsors there. And I'd like to thank those who contributed slides and information to this particularly, and particularly Ming Kai, Ansel, Chi, and Bernadette, who specifically gave me some slides for this talk. And I thank you for your attention.
Questions? So, beyond labeling PD-L1, have you thought about how you might track T cells independent of PD-L1.
We've been having those discussions, very relevant with a lot of different people, and part of that is to find not just something that's going to, how will you do that labeling, how will it be selective enough, and then to be able to differentiate the T cells that have infiltrated the tumor to what's going on. And I think, and this is where we're really happy with Bernadette, because we're going to need probably a lot of time to be able to show that the longer-lived isotopes are going to be very, very relevant there. And so we just had a discussion Friday with a couple groups trying to figure out what the best mechanisms for being able to do that. But these are great and really important areas to be able to differentiate the circulating T cells from what's infiltrated. So, absolutely.
Other questions? Well, Richard, thank you.
Okay.
So changing gears ever so slightly to an altogether different topic, and no less important. For those of you who have the privilege of working on the Cancer Center grant, you know that an area of focus by the National Cancer Institute has been addressing disparities and engaging your catchment area. And we're very fortunate to have Andrea Silber as one of our leaders in that regard. In 2015, the Cancer Center launched the Diversity and Health Equity program within the Cancer Center, and Andrea was appointed as the incumbent assistant clinical director. Andrea is an associate clinical professor of medicine, has certainly led efforts both in breast cancer and in our disparities work, and is going to speak to us today of changing the odds. So Andrea, thank you.
Is that open?
Not that I'm an expert, but
Yeah, I was going to say, I'm definitely not an expert in this.
here you go.
Okay. Thank you so much, Charlie. Thank you for the introduction, and thank you for helping me put my slides up here. I can start out by saying I am not a mathematician. What we're going to be talking about today, two parts. Really, first talk about defining the problem of cancer healthcare disparities, but the second part is going to be talking about the opportunities, talking about clinical trials as a strategy and potentially a solution to closing the gap and improving outcomes. This is how the National Cancer Institute defines healthcare disparities. And we're getting away from using the term cancer healthcare disparities. This was the term that was exclusively used before 2005, and now we use the term cancer health equity or health inequity. As a matter of fact, the WHO defines disparity as something that is unfair and avoidable. That veers away from biology and deals with social consequences of some human behavior. So the next thing is, why should everyone care about this? Dr. Fuchs pointed out that the NCI is very interested in this. Well, certain groups disproportionately suffer from cancer, and that leads to a loss in productivity, premature deaths, and impacts major communities. And one of those communities is the community of New Haven, where we all are. And this is that shows that people of color are disproportionately affected by cancer. We've seen a 23% decline in cancer mortality over the past 2 decades, but given that decline, cancer deaths are still 25% higher in African Americans in the year 2017. So let's try to dissect the disparity. Some of the things are things that are easy to target. If we talk about a preventable cancer, well, then maybe we can do something like have increased number of smoking cessation programs in inner cities and try to prevent cancers. But some of the things that cause these disparities are very complex and are hard to design a very targeted intervention. Kaiser Permanente presented a trial that's called the Pathways Study, and they looked at breast cancer mortality in the Kaiser Permanente enrollees. These were women who had the same access to care, same insurance, adjusted for age, adjusted for stage, and they still found a 59% increase in breast cancer mortality. They then looked at things like body mass or physical activity, and they still weren't able to explain that disparity. And their conclusion was this has to do with socioeconomic status. This is something that is less easy to solve. So some of the reasons that you may see this difference in outcomes, one of the reasons is genetic. Is there such a thing as a genetic difference in different groups? Well, race is a social construct that's based on a phenotype that may be a marker for social factors that influence health by people of a shared ancestry. But there was just an opinion piece in the New York Times on December 8th that stated that physicians are doing science a disservice by talking about racial and biologic reasons for adverse healthcare outcomes and said it's time to do away with that. This is an area of big controversy, but it's something to think about. You can look at something like hypertension. Hypertension is really common in African Americans in the United States. Hypertension is not common in Africa. Now, why is the difference? Is that a response to some of the historical things that happened to black people in the United States? We don't know the answer, but it clearly is a combination of both biology and social factors. But you can look at things like difference in nutrition, physical activity, and lack of early detection. I'd like to give a shout out to Beth Jones, who's my co-director here, who's launched a screening program that targets inner city New Haven with screening and has been successful in getting people that early detection and prevention strategies that are so needed. So why does someone want to do disparities research, and why is this so important? Well, we can answer questions that have been unable to be answered so far when we're looking at America's cancer problem. Some of the information that we have gleaned is from clinical trials that enroll the wealthiest, the healthiest, the best educated, and when we analyze those outcomes, we may be looking at improvement in cancer outcomes, but they may also have better 401ks and better SAT scores. Are we looking at really an intervention, or are we looking at a lifetime of good health? So it's really important to look in our real communities to see what we're doing and how our cancer care is working. And we need to look at that across the cancer continuum. We need to look at it in the prevention sphere and also at end of life. The largest clinical prevention study we had was the PCLO trial, looking at prostate, colon, lung, and ovarian cancer. It enrolled 155,000 Americans. 1% were Hispanic, 5% were African American. So we really can't answer what prevention looks like in our American community, which is increasingly becoming more diverse. Otis Brawley is the CMO of the American Cancer Society and made this statement about clinical trials. And now I'm going to transition into talking about clinical trials as a means to improving these cancer outcomes. I'm going to talk about them in general, but I'm also going to talk about our work in New Haven and what we have accomplished and what we have yet to accomplish. So you can see here in our country, and this is an old slide, but a slide that is used. I'll show you updated data in a few minutes. But you can see here that blacks and Hispanics have traditionally not participated in our federally funded clinical trials. But when you look at some of the cancers, like prostate cancer is much more common in African American men. The incidence is higher, the mortality is higher. Kidney cancer is more common in American Indians, liver cancer in Asians, and cervical cancer in blacks and Hispanics. If the people we are studying are not the people who are representative of the disease, we've really missed an opportunity. Well, who participates in clinical trials in general? Most adults don't participate in clinical trials. The elderly, the ethnically and racially diverse traditionally do not participate. This is in contrast with the pediatric population, where it's greater than 75% of pediatric patients with cancer participate in clinical trials, and they're extremely diverse. So what do kids get right that adults get wrong? Here are my updated figures that were presented at the AACR Conference on Science of Cancer Health Disparities. And you can see, even though we're looking at more recent figures, we're not doing any better. One of the conclusions of the author was that we're even doing worse. The more we are doing studies based on precision medicine or personalized medicine, the less likely we are to enroll diverse populations. So despite the fact that our demographics are changing, our numbers are not. Let's go to Connecticut, the state that we all live, this green state, which is a little bit white due to the snow now. But what you can see about the state of Connecticut is that Yale Smilow Cancer Center serves the entire state. That is our catchment area. But keep in mind, Connecticut is a highly segregated state. The non-white patients or people live in mainly urban areas such as Bridgeport, New Haven, Stamford, Hartford, and to some degree New London and Waterbury. And urban centers have disproportionately low socioeconomic status inhabitants, and the cancer burden is higher in our urban areas. So now we're going to talk about New Haven, which is our neighborhood catchment. This is a slide that from my colleague Beth Jones, and what it shows when you look at Connecticut, New Haven County, the home of our cancer center, has higher incidence of some cancers, and these are the common cancers, some of the common cancers, lung and breast cancer, and it's even more common in Hispanic Latinos, which is the largest growing demographic in New Haven. If it was the largest growing demographic before this fall, it's even going to be higher thanks to Hurricane Maria. There is going to be there's going to be a new influx of displaced residents from Puerto Rico, and we're going to see some of the things that I'm showing you today even increase. How do people find out about clinical trials if you're not at this cancer center? Well, they hear about them from physicians and from other trusted sources. They can also search out options on their own. But when you're searching out options, that means you need to be computer literate, you need to be health literate, and preferably speak English. If your physician is not a physician at the Smilow Cancer Hospital, but is a physician that you may see, or a health provider rather than a physician that you see at a walk-in clinic, that you see in a minute clinic, you may not hear about clinical trials. There is a strategy now using social media, targeting Facebook groups, Google groups, and using YouTube videos to reach out to communities, particularly ethnically diverse communities with cancer. But there are some ethical considerations of whether it is fair to target a group that, say, maybe a triple-negative breast cancer survivors group and try to reach out to them for clinical trials. But this is a new strategy and probably will turn out to be an effective strategy. So let's talk about some of the patient barriers to clinical trial participation. Well, the first thing, let's think about study design. If you have a study that excludes people with a blood pressure of over 140/90, well, take a woman who maybe has hypertension, bring her into my clinic, tell her she has cancer, tell her she has a chance of maybe suffering cardiac damage from a clinical trial, and measure her blood pressure and see if she's eligible to be in the study. I'll give you a little hint. Answer, no. And if you say to that woman afterwards, I'm sorry, I wanted you to be on the clinical trial, but you're no longer eligible, what kind of message are you giving? People have hypertension, they have diabetes, they are obese. That's our country. So if we're going to exclude those patients from the get-go, we're going to be excluding our citizens. But there's also a lack of knowledge about clinical trials. A lot has been out there in the news about historical abuses, whether it's Tuskegee or Henrietta Lacks. By the way, Henrietta Lacks is a story that was on HBO this year with an Oprah Winfrey movie. When I've done focus groups, everyone in the New Haven community knows the story of Henrietta Lacks. And also, there are personal and practical obstacles. The obvious obstacles are things like language or transportation, but some of the less obvious obstacles, if you have Section 8 housing and you get a call from Yale New Haven about coming into a clinical trial, you may be worried that you're going to lose your housing. You may be worried that we send information to ICE or to attorneys, to collection agencies. Patients are worried, and they're worried about their privacy and where their information goes. The other thing is so much of our clinical trial work is done by telephone interview. If you work in a factory and a study nurse calls you during the day, what's the chance you're going to be able to pick up the phone and complete the questionnaire? It's very unlikely, and then we might get a report back, your patient is ineligible because they were unable to be compliant with the study. That also sends a message. And there are cultural influences and complications of low health literacy. There are institutional barriers, even at our institution. Some of the institutional barriers are people may be unaware of what clinical trials are available, but there's an administrative burden. If you're going to consent someone to a clinical trial who's not health literate and who doesn't speak English, and maybe by cultural norms wants to involve their entire family, it can take hours. If you're not well informed, you may not know how to bill for that, you may not know how to book for that, and it may make you look like a less productive physician. There are solutions to this, and there are people at this institution, at YCCI, who know how to get around that, but all physicians need to learn those strategies. But I maintain that if you can consent someone for chemotherapy, we have to consent everyone for chemotherapy. You can consent someone for a clinical trial. And then the final bullet point is maybe a subjective judgment that this patient would not be interested in a clinical trial. So I'm going to talk about Own It, which is the program that we have operative now in the breast DART standing for Disease-Aligned Research Team, but is going to be available throughout SMILO and is about to be rolled out for all the DARTs. ONIT stands for Oncologists Welcome New Haven into Trials, and it really has to do with welcome. It is not about increasing numbers. It's about increasing community engagement and getting people interested in participating in clinical research. And the program targets the institution, Yale, the community, New Haven, and hopefully policy changes. And in New Haven, I know Dr. Fuchs talked about the new leadership positions. They're really only 2 years old, where this is a part of our executive committee, and we have been able to integrate into some of the teaching curriculum as well. This allows us to collaborate with some of the translational programs and to bring relevant science discovery to minority or diverse communities. If we don't have this forum, we will not have this collaboration. And the collaboration has really multiplied over the past year and has provided us the opportunity to participate in certain NIH funding opportunities, and there will be more in the future. So what are the objectives? It's to reduce the institutional barriers, to make it easier for the physicians at and the other health providers at Smilo to enroll patients, to reduce barriers for both the community health providers and its underrepresented citizens. And a long-range program is to try to reduce the barriers in government and to try to influence corporate policy. A lot of the clinical trials are sponsored by pharma. I think pharma is getting the message that a diverse America is a marketplace, and therefore some of the clinical trials need to represent the marketplace that they're trying to enter. And that's entering the marketplace with more than just branded material, trying to look at trials that deal with real people and answer real questions. I'm going to present the data from the ONIT breast dart. This is thanks to Adam Roshka, who did this on very short notice for me. And we did get the month of December in there. And you can see in our breast dart, we've had consistently, since ONIT has been launched, a greater than 20% enrollment of Blacks and Latinos. And even though this number may not be as high as I would like it to be, keep in mind, breast cancer is one of those diseases that is less common in minorities. That's the first thing. It is much more common in Caucasians, even though the mortality is higher in Blacks and Hispanics. The other thing that these numbers don't show, there's a tremendous percentage of, quote, unknown. Who are those unknown patients? Are they people who are biracial? Are they people that we didn't capture data? That's one thing we're going to look at, because our numbers need to be better in terms of capturing both racial and ethnic data and making it really comfortable for patients to share that data. So our study is to try to understand why they participate in low rates, to look at our patients' knowledge about clinical trials, and to understand how their racial and ethnic differences may affect their experience in clinical trials in the breast center. And this is a pilot program that we're launching in the breast dart, but we plan to take that information and bring it to other darts to help design clinical trials that are truly inclusive. And what we're going to ask is what I call the 4 W's. Who's eligible for this clinical trial? If we have clinical trials in the breast dart, but no one who's diverse is eligible, well then that's one reason, and it's an easy fix. Were people asked? If people aren't asked by their healthcare provider, how can they possibly participate? If they were asked, do they participate? And if not, why not? So the study that we're doing is going to be conducted by iPad. It's anonymous. We plan to enroll 150 patients over 6 months, and then to interview and have a focus group for 20 of the patients from those traditionally underserved populations to try to understand why they didn't participate. We do believe that this information will help us make a more inclusive environment in the breast center. Our staff on this study are bilingual and are representative of the population we're trying to recruit. And we even have a Yale undergrad who's bilingual who's volunteering on this study. I'd like to end with a slide that brings me to a very both poignant and hopefully optimistic conclusion. The woman on the left died 2 days ago from her triple-negative breast cancer. She participated in 5 clinical trials. She survived for 4 years with metastatic triple-negative breast cancer, and she engaged many of the patients in the breast cancer, telling them about the benefits in terms of her outcomes for participating in clinical trials. I couldn't do this work without her, and I thank her. So anyway, thank you very much for listening, and available for questions.